Hi, Dr. West.
Hello, Darryl. Nice to see you.
Yeah, good to see you. For our audience, Dr. West and I are co-investigators on a clinical trial that's winding down after many years of work, hard work by us and several other investigators and lots of grad students and hundreds of participants who are the real heroes of this project. Dr. West, you have a presentation for us today about identity and sexuality and vis-a-vis conversations men with prostate cancer have with their doctors and other folks. Is that right?
Yep.
Okay, good. So why don't you share your presentation with us and then we'll talk about it.
Okay.
Okay, if you could make that full screen.
Yeah, there we go.
Great. So please go right ahead.
Okay, I'm going to be talking about the rhetorical reconstruction of identity in gay and bisexual men with prostate cancer in recovery. This is an analysis of quantitative comments from Restore 1 study, which had approximately 200 participants. A lot of them came from Malecare. And this study is continuing with Restore 2, where we have about 400. Both studies are the largest studies to date studying prostate cancer in gay and bisexual males. I'm analyzing the qualitative comments from Restore 1, and where patients talked about their recovery. And I want to start by saying that even though I use the term rhetorical, don't let that throw you. Rhetorical is kind of a scary word. It basically means persuasion, including self-persuasion. It's a complicated concept when it comes to identity because it presumes that we're persuading ourselves as we create an identity, and we are persuaded. It uses techniques and tropes that were first identified about 2,000 years ago. They're still effective, and we know they're effective because the term rhetoric is still dismissed. We still hear the term, it's mere rhetoric. But to orient us, what we're talking about is, first of all, patient-provider communication in this population of which I'm a part. This communication is at best problematic. When communication between the physician and the patient fails, there's a lack of trust, and it's been demonstrated in a large number of studies that outcomes are worse when this trust is lacking. One of the exercises that we do with physicians is we ask them with a patient to find out exactly where their communication skills are falling apart, to do this exercise, to write down what they think they've said to the patient, and then have the patient write down what they think the doctor said to them. And one of the most amazing things is that no matter how well you do this, how many times you do this, one of the things you discover is that there's a very large gap between those two texts. So what we focused on is patient-centered care, which basically for the layman is to tell the physician to shut up long enough to hear patients. Okay. One of the studies that was done in 2018, published in the Journal of General Internal Medicine, found that it took only 11 seconds for a physician to interrupt a patient. So patient stories are not being heard. And one of the assumptions of this presentation and my work is that stories are actually crucial to care. If you don't know where the patient's coming from, if you don't know who they are, you really can't treat them. One of the stories I tell is a colleague of mine who was doing a cardiac workup on a patient and came into the exam room and told him that things looked really good, didn't have to worry. And the patient looked at him and said, well, that's all very well and good, but what about my alcoholism? Which completely changed a differential diagnosis. It was something that the physician never asked the patient, and it was something that would have affected the outcome severely. So we listen to patient stories, but every patient story is supposedly idiosyncratic. So how do we avoid an idiosyncratic impasse? What do we do with these stories? What are we supposed to do with them? One of the things that I focus on is narrative theory. This is something that in the medical field is championed by Rita Sharon, depending on what her mood is, at Columbia. She has a program, graduate program in the medical school, teaching people how to study narrative and apply it to medicine. The other great person in this field, at least in my opinion, is Susan Sontag, who focused on patient narratives and developed concepts like narrative competence. And one of the things that she talked about was that there are patient narratives, and patient disease narratives follow patterns. Okay? Some are universal, some disease and population specific. For example, a universal narrative is that disease is a disruption followed by a new normal. We use that term at this point. It sounds like a cliche because it's coming out of everybody's mouth. But we'll get into that in a little more detail. We've studied qualitative comments by gay prostate cancer patients to see if there were unique narrative patterns in this group. Now, initially, these qualitative themes were mapped across Masters and Johnson's sexual response cycle. In addition to the normal cycle phases of excitement, release, recovery phases, we found themes of identity loss, accommodation, and people talking about a new equilibrium. What this suggests is that there's a fundamental link between change in sexuality and identity post-treatment. We then remapped these themes onto TODOROV's narrative stages. This tends to be a fairly complicated and vexed topic. So I'm going to show it to you by referring to Jurassic Park. For those of you that were born after its release or have forgotten what the story is, I'll summarize. An industrialist, John Hammond, creates a clone park, reclones dinosaurs, brings them back. A disgruntled computer program, Nedley, rightfully the villain in this piece, shuts down the electricity to steal an embryo. When the electricity is shut down, gates open, dinosaurs escape, fun ensues. Okay? So we have an equilibrium. We have this park that's created. We have a disruption in the equilibrium. Okay? This is one of Todorov's phases. The electricity gets shut down. There's a recognition that something has changed. In the movie, Tyrannosaurus Rex looks in a window. There's an attempt to repair the damage. And when power is restored, we have a new equilibrium. But the new equilibrium is not the same as the old one, because at the end of the movie, what we discover is that there are shells, which means that the dinosaurs that were bred not to reproduce are reproducing. Now, Todorov, who taught at the Sorbonne, also did film theory, published in Cahiers du Cinéma. His cinematic theories, at least in Hollywood, are called the most important book of the 20th century. He basically believed that there are two narrative plots. Okay? One, a stranger comes into town, disrupts the equilibrium, sets this whole process in motion. Or the second plot, a youth protagonist leaves the town and returns and sees the town in new light. Yeah. Now, in some aspects, all of disease can be viewed in this same cycle. An equilibrium is disrupted and is restored in some format. And this is true of all disease cycles, at least on a physiological level. Now, the first stage, Todorov's first stage, is the initial equilibrium. And that's a vexed starting point with gay and bisexual men that are surviving prostate cancer, mainly because they're AIDS pandemic survivors. Okay? So there's this point where they have lived through trauma previously. And there's a couple theories about what this does to a population. It can either act as a trigger or it can act protectively. In my case, it was a trigger. When I went through diagnosis and treatment, it brought back memories of the AIDS crisis, which I lived through at UCSF when I was working there. And it brought back memories of doctors not knowing what you're talking about or who you are. Okay? But one of the things about this population in its initial stages, when they present to physicians, is that there's already a core split in identity. Okay? As gay men, I had to face questions about my own manhood in the context of my sexuality at a very early age, one of the patients wrote. So by the time I received my prostate cancer diagnosis, I'd already come to terms with the fact that my sexuality and my manhood were independent of each other. My needs are different than a lot of other men. Even though you're going through the same disease as a gay man, you're going through it differently because you already have all these other stereotypes going against you. One of the markers in this initial stage is that sexuality is a key marker of identity. Okay. In 2013, a Pew poll found that was true in 75% of all gay men. Another thing is that there's a performative aspect to gay identity. We're performing all the time. One of the patients told me that the real drag performance, the real drag show, is not taking place on stage, but is taking place every day when gays interact in a straight society. So there's this whole performative aspect of identity that's built in during this initial vexed starting point where you have a core split in identity. The disruptive stage, okay, is the second stage of the TODOROV acknowledges. It's diagnosis. And it's basically one of the characteristics is that it's liminal. Patients are perpetually waiting for the next shoe to drop. And there was a lot of anxiety, a lot of stress. People are developing sleep problems. The strongest emotion was just the fear of what was going to happen. It was kind of numb, didn't even really understand what he was saying. Now, in this population, there is residual trauma protection. Okay? Some of the patients said, I've been wondering why I'm not more freaked out. My cohort are chiseled veteran survivors. We grew up when homosexuality was still illegal, and we risked jobs, family, and religious damnation and careers to claim a life worth living, forged a community, and lived through the worst decades of the AIDS epidemic. Now, one of the features that you can look at when you look at these comments is that there's some use of first-person pronoun, but often there's a lot of impersonal comments. There's already alienation built in. This thing is in me. This third stage is recognition. Okay? This is the one where Tyrannosaurus Rex is looking in the window, where we recognize that something significant has changed and that it will never be the same. We're different with sexual changes as the outcome. Gay, bisexual, male patients emphasize identity. Sexual changes affect us differently because our practices are different and are defining. Okay? This narrative stage of recognition is disorder, and it plays out in the body. Okay? Symptoms of treatment reflect disorder. Urinary incontinence, in general, signals a lack of bodily control. They report climacturia, urinating during climax. Bowel problems emerge. Okay? Erectile dysfunction is common. Okay? And anal penetration requires 33% more firmness than vaginal penetration. So a lot of the recommendations that doctors are giving and assume do not apply in this population. Penis size is reduced. It's like I had a penis transplant. That was the hardest. The cancer was easy. So what patients are saying is that the changes in the body, the disorder that's coming about because of treatment, okay, is even worse than the cancer. There's one case, the patient is saying, my penis was unrecognizable. They don't tell you that. And this echoes a consistent theme of surprise. Patients are surprised by what they're experiencing. They haven't been prepared for it. In one case, the patient told the surgeon that my dick was smaller, and he said, no, it's not. And I said, yes, it is too. There's a wounded, lost identity. Okay? And I think this is where Sontag's genius comes in. Symptoms exist in a body that is difficult to read. When you can't read your body, okay, something significant happens to your sense of identity. Let me explain that. If I wake up in the morning and my shoulder hurts, what I say is, oh, I must have had the air conditioner on too high last night. The covers must have slept. I'm able to assign a cause to that symptom. Okay. But what happens in a disease process is you reach a point in the disease where when you have a symptom, you can't tell if that symptom means you're getting worse, if that symptom is a consequence of the treatment or medication you're taking, if it's a side effect, whether what your experience means you're getting better. In other words, you can't read your body. Okay? And when this is linked to sexuality, when you can't read, okay, what's going on sexually, okay, then what you're talking about in the case of this population is an identity crisis. The damaging effects of prostate cancer treatment affect more than erections, penile size, and penetration. As one patient explained, I've lost something that was really important, my identity, I guess. The I guess signals a tentative interpretation of such a fundamental loss. Okay? There's an inability to read the body. Okay? I never thought about ending my life after surgery, but I can see where that could happen. If that's your identity and then that's gone, or devastated, or you're just feeling totally unsexy as you reek of urine, I get it. Now, there's attempts after this stage, TODOROV would call it stage 4, to reconstruct identity. And there's a number of ways this can happen if you examine the comments in this patient group. Strategy 1 is autonomy or Verschiebung. Sexually insertive tops become anally receptive bottoms. There's a switch in roles, or there can be. In this population, 8.2% reported as tops versus 41% that reported as tops pre-treatment. So there's a significant change in roles here. 64.7 reported a bottom role after treatment versus 36.5% pre-treatment. But top and bottom are more than sexual positions, they're identity roles. Okay? I was a top, I am a top, I guess. I've been very sexually active my entire life. And it was very important to me. Losing it was just devastating. Remapping the sexual body remaps identity. Okay? Sex was a really important part of my life. I've lost something that was really important, not just recreationally, but part of my identity. So one of the ways that identity is reconstructed, okay, is in changing sex roles, there's also a change in identity. A second way this happens is a strategy called metaphor. Rhetorical. I'm using the Freudian term there. Metaphor and metonymy are, of course, Lacanian terms. What's at the basis of that is something I think that sounds complicated, but is really very simple. And that is that our consciousness is structured like a language, by language, as we learn a language. That's how we map the world. So if you want to see how someone's worldview is mapped, you simply look at the language that they use, which is what I'm doing here. Metonymy refers as taking a part for the whole. In this case, we're looking at top and bottom sexual organ parts. Another strategy is metaphor, which is condensation. So instead of displacement, we have condensation. So here, there's a repressing of the lack or delocalizing of orgasmic pleasure. So we found in one case, and this is fairly typical of this strategy, I can enjoy the act even without a prostate. That's what I thought was kind of strange at the beginning, because I figured it was prostate stimulation that was really what the bottom partner enjoyed. I can still enjoy the feeling of being filled sexually. It's more than just physical for me anyway. I think it's also emotional. I serve as I take the role at the bottom, and that's fine for me and satisfying for me. Okay? So there's a delocalization of orgasmic pleasure from the sexual organ to something metaphorically more. And that's one of three different attempts to reconstruct identity. I've discussed two, and I'm going to save the third for the last. But a new equilibrium is established. Okay, the original stasis is disrupted by major changes in anatomical functions. Okay, the anatomy is not functioning the way it used to. Those include changes in penis size, loss of ejaculate, incontinence, radical decrease in libido for some. Emotional reactions to this include shock at diagnosis, reactive depression, sex-specific situational anxiety, where people get very anxious when they are faced with sex, grief, and enduring loss of confidence. These are described in terms of identity. The body is read as text. We're moving from insertive to receptive as a metonymic shift in bodily text, as is the metaphorical interpretation of delocalizing orgasmic pleasure. When a new normal is established, it is signaled by a larger context. Okay? It's important to look at ourselves as whole people. That was the difference that allowed me to recognize this diagnosis as a gift, that this wasn't necessarily a death sentence to me, but just a change in life. So it's putting all of these changes into a larger context. Now, one of the things that I did not mention was a third coping mechanism, which is one that leads and needs to be studied more, because it leads to a lot worse outcomes in terms of patients being satisfied with the quality of their life and in some mental health scales. And that is, in a narrative, one of the things when you create a narrative is that details drop out. Okay? So we have 1,000 details in our life. When we reduce that to a story or to a narrative or to a memory, which is a narrative, okay? One of the things that happens is details drop out. We signify certain things as important and forget the rest. Now, what's important about that is that because details drop out when you're creating a narrative, you can, in fact, change outcomes fairly significantly. There are certain steps in these narratives that we've been talking about, and you can skip steps. But one of the strategies that, at least on the surface, seems to be very unhealthy is jumping from diagnosis to a new equilibrium in one step. And you find comments where patients are just saying, oh, I'm just getting old, I don't need sex. This is probably just a blessing because I don't have to deal with any of that anymore. This is a strategy, unlike the last two, which does not seem to lead to very good outcomes. But again, this is one strategy that needs to be studied more. Now, in summary, a disease narrative is how the course of a disease is experienced in a specific population. We've been looking at disease narratives in gay and bisexual men post prostate cancer treatment. That's the population. And we've been looking at the ways that they experience that. The prostate cancer disease narrative is different in gay patients. And I would argue that the reason that it's different is because sexuality and identity are very closely linked in this group. So that if you look at heterosexual outcomes versus gay outcomes, there is a difference. And I think this is what accounts for it. Patient narrative conforms more to a disease narrative than to the generalized course of the disease. Now, by that, I mean we have a generalized course of prostate cancer when the practitioner, the doctor, assumes that all men and all male sexuality is the same, treats all of these patients the same, we tend to have bad outcomes in the non-normative group. So knowing the disease narrative helps intervene in patient narrative. Intervening in that narrative can help change the outcome. But the patient needs to feel understood to even begin sharing the narrative. Okay? I needed more of my medical care taking into account, or perhaps even being set at the forefront with my sexuality. The approach to my medical care needed to have my gayness at the lead.
Wonderful. That was, and here you are back again. Good. This is that was stunningly provocative and an interesting presentation. I hope our audience didn't get lost on terms and names and, being exposed to TODOROV perhaps for the first time and such. Hopefully there are people who grew up watching Godard and Truffaut and reading Cahiers du Cinema in English and maybe a bit more familiar. But let's stick to. I have 5 3x5 cards filled with notes and questions. So I won't go through all of them, but over the next 10 minutes or so, the idea of it seems like you're focusing on what the doctor needs to change or better understand. What might be useful for the gay man patient to understand or sort of evolve around?
Again, I think we're in a unique position, this population is, because I think one of the significant changes in the history of medicine occurred with AIDS patients who stood up and told doctors, I'm not going to fucking take this. You need to treat me as a human being and you need to stop being afraid of me. That was a watershed moment. And I think the change toward patient-centered care. I focus on the doctors because being a part of that generation and this population, I think we can stand up for ourselves, and I think we need to. When I had a primary care physician, and I got along with him great. He was a mad Russian, and we would just thoroughly enjoy each other when we met. He left, and so he recommended a few people in his practice, but he recommended that I interview them. And so I did. And the third or fourth person I interviewed, I said, unless you're willing to take a half hour to get to know me without talking about medicine, to get to know my husband, to get to know my children, okay? Unless you're willing to do that, and we can enter a room, the first time I enter an exam room medically, we can enter as equals. You bring medicine to the table, I bring a knowledge of my body to the table. And that's how we talk about it. And I said, unless you're willing to do that, you just well hang up now because I'm going to keep looking. And he said, Josh said, this is Bill West, isn't it? And I said, yes. And I said, how'd you know? Turns out I taught him in medical school, taught a class, but he agreed to it. And we met for a half hour. I got to know all about him and his family. He got to know about mine. When I walk in the office for an appointment, the first thing he asked me about is my husband, the kids, how everybody's doing it, because he realizes that all medicine is family medicine, that unless you have the partner involved, unless you have the family involved, you really can't treat the patient. They don't have to be in the room, but you have to know where everybody is in relation to that patient, what effect they have on that patient. My doctor will tell me, I recommend that you do this. An example is he recommended that I get a colonoscopy. And I said, no, I'm not going to do that. And he said, why not? I said, I don't feel it's necessary. I'm reading my body. I know your expertise. I know the studies that you have behind this. Okay, but I just don't want to put myself through that because I don't think it's worth it. There's no family history of this. I know there's a genetic component of it. I know that there are also risk factors, which I'm not being exposed to on a huge level. So he said, okay, it's your body. You do what you want. But how about we compromise and you start doing some occult fecal bloods samples for me so that I at least have some data points that I can look at. You're reading your body. I need to read data. Okay? So that's the compromise we came to. So I think it's important for gay patients, and I think that we're in a position to do it because we've been trained through the AIDS epidemic to do it, is to simply say to doctors, and it's hard to do when you're dealing with a specialist as opposed to a general practitioner, but just to say to them, wait a minute, you don't understand. I'm a gay patient. This is what that means, okay? And you have to be aware of it when you're giving me recommendations. So, yes, I do focus on the physicians because those are the people that I primarily train. But I do have a lot of faith in this subgroup, this population, in being able to defend itself.
Yeah. And for the heterosexuals in the audience, of which there probably are a majority watching this, the idea that you and I and others are talking about physical characteristics of identity. I could hear, in the back of our virtual audience, somebody saying, but wait, isn't identity about who we're attracted to? Can't you sort of maintain the integrity that you had as a gay man prior to prostate cancer by just owning and having agency over the idea that you're attracted to men? And doesn't that define you in total?
Well, again, I'm going to revert to Lacan, who at least I attended some of his lectures when I was at Sorbonne. He talks about desire as following a path of metonymy, and that is we aren't attracted to males or females. We're attracted to body parts. That when desire kicks in, okay, for the straight population, they may be attracted to breasts. Some are breast men, some are leg men, some are ass men. And it's not just gender. We're attracted to body parts in the process of desire. That's how desire works. That's how metonymy works. And so I would argue that because we're dealing with body parts, and those, in some sense, really do constitute identity at a larger level, that identity is to a large part inhabited in our body. We tend to think of our identity as being something mental, but I think a lot of it is really in our body. I tell people that question that, if you don't believe me, take a year off or two and read patient narratives of women that have gone through breast cancer. That's population is very, very different from us. And I think you can see just how linked body and identity are in that population, and we're no different.
Yeah. While you were doing your presentation, Joseph Campbell came to mind, and the idea of the hero's journey and such. Is there any utility in patients understanding what that heroic journey is?
Yes. What TODOROV is talking about, and of course he's in that whole narrative tradition, that the whole narrative theory starts with a lot of Russian formalists that are studying Russian fairy tales. And then you have people like Jung and Joseph Campbell and all of these people that are starting to map the stories that we tell each other. One of the things that I tell pre-med students why they should listen to patient stories is that we basically are just the stories that have been told to us, that we tell ourselves, okay? Whether those stories come from our family, from our religion, from our education, they really are all stories. One of the things that Joseph Campbell did was he showed that those warrior mythologies, those stories, follow a distinct pattern. That's exactly the same pattern that you find in religious narratives, where you take the story of, say, Jesus, who descends into hell, into an afterworld, and then returns to a normal. This is all, it's typical narrative patterns. One of the things I do that drives my husband absolutely insane is I believe that there are really only about 10 successful narrative stories that have ever been told that humans resonate with. So when we're watching a movie, about 9 or 10 frames into it, I'll say, that's story number 5. And Simon will jump up and say, "You've ruined it for me." Storm out of the room. But it's true. There's, there's certain stories that resonate. And one of the stories is this TODOROV narrative, which is why Hollywood has latched onto it and said this is the most important book of the 20th century. because what they say is in order to have a successful film, you have to follow that pattern. You have to have an initial equilibrium, a disruption in it, a recognition of the disruption, some kind of remedy to that, and then reestablishing a new normal at the end, a conclusion that's satisfying, which is why I use Jurassic Park in this, because that's an archetypal pattern where you see this. But again, Todorov said, they're basically two narratives. Protagonist comes to town, disrupts equilibrium, or protagonist, young male or female, leaves town, goes out into the world, comes back, and sees the world in a totally different way, which is basically the Odyssey.
Yeah. And the struggle for all patients is to both identify and sort of install the new normal as you're describing it. Mm-hmm. Yeah, I mean, for our audience, any quick tips around that?
I think that's why I focus on physicians, and this would also apply to friends and sites such as yours, because I think there's a lot of ways that narrative can go wrong. I indicated at the end of my talk, one of the ways that I think it does go wrong, and like I say, that needs more study, but at least preliminarily, it looks like people that are in that category don't do well. Where they simply jump from beginning to end and skip the whole narrative process and just say, well, it's over for me. I'm an old man. It doesn't matter anymore. That's not a good outcome. When people are, when you identify what the narratives are within a population and within a disease in that population, you'll find that there are certain successful narratives. I pointed to two of them in my talk. One is where there is a change in role, where people adapt, and that change in role is a change also in identity, and that's not easy. That's something that people have to come to terms with. I think the important part is to recognize what the successful narrative patterns are, and to recognize that it is a narrative, and because it's a narrative, that details can change. That when you retell a story, certain details will drop out. And if those are toxic details or unhelpful details, that drop out of a story over time, then the story can be a lot more successful. The narrative can be successful. I think it's important for physicians to recognize that there's a number of narrative paths that this population can take, and to let them know that there are a variety of ways that they can take this journey. This also applies for friends and for support groups, so that if they recognize somebody getting off on a dangerous path of denial, say, no, none of this matters. I don't have to go through this. It's too painful. I'm just going to jump to the conclusion, that they can stop and say, you may want to reconsider that and consider the benefits of actually going through the narrative.
Dr. West, thank you for this marvelous conversation and presentation, and for your good work that benefits all of us. And welcome to our conference.
Okay, thank you.